get us started with introductions. Okay, so Alyssa Johnson. If you all will just share who you're with and who you are. We'll give Elisa a second and come back to her. Angela.
Good afternoon, everyone. Angela Hageman from ETSU Addiction Science Center, and I also serve as the treasurer for Carter County Drug Prevention.
Thank you. Ashley.
Hi, I'm Ashley Williams. I'm with the Elizabeth and Carter County Public Library, and I also serve as the chair of the steering committee for Carter County Drug Prevention.
Thank you. Chris.
Good afternoon, everyone. I'm Christopher Lewis. I'm the coordinator with the Addiction Science Center at ETSU.
Thank you. Dr. Slawson.
Good afternoon, everyone. I'm so pleased to be a guest today. I'm a professor and chair of community behavioral health at ETSU. I have my evaluation students here.
Yeah, so if you all want to go ahead and introduce yourselves too, in whatever order feels good to y'all.
Hello, everyone. My name is Adekunle Oke. A second year ETSU student, HSMP concentration. And we are here speaking on behalf of my classmates here to discuss evaluation projects with you all. And it's a great privilege to be here. Thank you.
I guess I can go next. Hi, everyone. My name is Fenose. I am in the Community and Behavioral Health concentration. And it's, I think it's a good privilege to be here presenting our projects here today.
Definitely. Now, Manul.
Hi everyone, I'm Manul Awasthi. I'm a second year Doctor of Public Health student in the Health Services Management and Policy Department. I'm excited to be here and present our work in front of everyone today.
Definitely. And Melissa?
Hi, everyone. My name is Melissa White. Sorry, there's two of us in the same room, so there's a little bit of feedback. Student as well in the epidemiology concentration, and I'm excited to be here and have had a really good time working with Carter County Drug Prevention this semester.
Excellent. Esther? Oh, you're muted. Uh-oh. Well, let's return back to Esther. Katie, go ahead, and Kathleen Tatro.
Hi, good afternoon. My name is Kathleen or Katie Tatro. I'm a second year doctoral student in Health Services Management and Policy. And as my colleagues have mentioned, we're really grateful for the opportunity to be here and for the opportunity to work with Carter County Drug Prevention this semester on our evaluation projects. Thanks for having us.
Yes, definitely. And Esther, I'm sad that she'll be back, I'm sure. Esther Adeniran, who's in second year EPI student, who is also a valuable member of our team. So thank you very much.
Thank you. Dolly.
Hey everybody, I'm Dolly Reeves, project coordinator for Carter County Drug Prevention.
Emma.
Hi everyone, my name is Emma Carpenter. I'm president of Carter County Drug Prevention Youth Coalition and a member of SLC on SAD.
Thank you. Lupe.
Hey everybody, for the survivor
Thank you. Lacey.
Hi everyone, I'm Lacey Hardigan. I am an independent evaluator researcher for EMT Associates. No, I cannot nurse any injuries. The acronym does not mean the same thing. We run the Tennessee Together student survey. So yeah, I'm just here to listen and answer any questions if you all have questions about that. And I'm excited to see the students' presentations today. I also teach part-time at Vanderbilt. So we're full on in presentation modes as well for classes. So they're really fun to watch, and I'm happy that Jillian invited me. So thanks for having me.
Thanks for being here. Mary.
Hi everyone, I am Mary Shell. I am a lead coach with Child Care Resource and Referral Agency.
Thank you. Melissa. We'll come back to her. Molly.
Hi all, and I'll turn my video on for a second. My internet is down, so I'm trying to do this on my phone, and the easiest way for me to do it is with my video off. Otherwise, it like freezes everyone's voices, so bear with me. Hi, I'm Molly Colley. I'm the Northeast Regional Director for Tennessee Suicide Prevention Network, and it's good to see all of y'all.
Thank you. Kathy.
Oh, hey, I'm Kathy Campbell. I'm the Community Engagement Director with Northeast Community Credit Union here in Elizabethton.
Thank you. Rachel.
Hey, I'm Rachel. I'm the coordinator for Recovery Court with Families Free.
Thank you. Norma.
Hey everyone, I'm Norma Morrison, and I'm a representative of Moms Demand Action for Gun Sense in America.
Thank you. I think Renee is back with us.
Can you hear me?
Yep.
Oh, good. Yay. Yes, I'm Renee, and I am with CHIPS Family Violence Shelter.
Thank you. Shannon.
Hello, folks. My name is Shannon Payne. I'm the Peak Mentorship Program Coordinator for the City of Elizabeth and Parks and Rec Service.
Thank you. Stephanie.
Hi, everyone. Stephanie Mathis, Research Faculty with the ETSU Addiction Science Center and Center for Rural Health Research. It's good to see everyone.
Thank you. And Vicki. And anyone else I missed? Elisa Johnson is here and having mic issues, so she's on with us. All right. So we will go ahead and get started. I am so excited to have our ETSU friends here with us today to share their amazing work with you all. I could not be more impressed with them and the work that they've done for us. So I'm really excited for you all to get to hear from them. And I will turn it over to the students and have them share with you.
Jillian, would you allow me to share my screen? Thank you.
Sorry.
Okay. All right. Can you guys see our PowerPoint now?
Okay. Where should I start? Okay. Hello, everyone. So we are the Carter County Drug Prevention Community Needs Assessment Group, and I'm Manul Awasthi, and I have Melissa White and Fenose Osedeme here in the group with me. So overall, our presentation today will include the purpose of the evaluation, the methodologies used, the findings that we have, and the recommendations. So before starting to talk about the actual needs assessment and what work we did, I would just like to quickly go over what a needs assessment is and the different components of a needs assessment. So basically, a needs assessment is a process that helps an organization determine what it needs to do to improve its current state. Like, you know, what processes and issues the organization should prioritize and improve or give more attention to achieve its overall goal. So basically, a needs assessment has 5 components. As you can see here, the first one is the community needs assessment, followed by the logic model for each problem that we get from the community needs assessment component, the strategic action plan, evaluation plan developed from the logic model, and the evaluation communication plan. So if you see here the bolded part, the first component of the needs assessment further has 5 subcomponents, which includes the definition of a community. So this basically includes the geographical location and, you know, the socio-demographic structure of a community, followed by the community history and forces and influences, the qualitative and quantitative data analysis, which will help us determine the root causes and local condition, especially like focus on youth substance use problems in Carter County, the current resources being allocated, and some other resources that CCDP could leverage upon, and the problem statements that we identified for each substance. So, you know, to give moving on to the evaluation purpose, basically to give some context to our evaluation, we developed a purpose statement, our process objectives, and some action items that were targeted to obtain the process objectives. So our purpose is to complete the first component of the CNA that I just showed you in the previous slide. And our process objective is to execute the first component of the community needs assessment as identified by Carter County Drug Prevention Coalition between September 2020 through November 2020. And some of our action items included, like, you know, identifying data sources for community needs assessment, determining the community boundaries and history, analyzing qualitative and quantitative data and interpreting our findings from those analysis, recommending best practices, and overall disseminating the findings.
So the first thing that we did with our evaluation was to develop a logic model for the community needs assessment based on the input activities, outputs of Carter County Drug Prevention Coalition. And so with the logic model, we see inputs, activities, outputs, short-term outcomes for this program, long-term outcomes, and the ultimate goals. So in terms of inputs, we had like primary sources of data for our needs assessment, and we had like sources from qualitative and quantitative data sources. For activities, as mentioned by Manul, we wanted to just kind of develop, you know, problem statements, identify current resources, and so we put that under like activities. For outputs, we wanted to identify gaps in knowledge between data sources and determine root causes of community issues regarding substance use in Carter County. And for short-term outcomes, we wanted to just increase resources in the community, improve knowledge, and intermediately increase utilization of these resources. In the long term, like in a couple of years, our goal with this assessment is to achieve reduction in drug use among the youth, and ultimately to prevent trauma or substance use disorder among youth in Carter County. And so below, you can see the data sources that we use to be able to achieve this particular needs assessment. And so in terms of how we went about our evaluation, we used qualitative and quantitative data. And so I will be talking right now about the qualitative data sources. Really, like mentioned earlier by Manul, our goal was to kind of just collect data, interpret the data to be able to develop problem statements. So we had 2 sources of focus group data for the qualitative data. We had focus group A and focus group C. We had 35 youths that participated in focus group A, but we had an aggregate data for focus group C, so we did not know the exact number of participants. And so because of that, total demographics for the participants were known. But then based on the data format that we had, recorded responses were obtained from Ms. Dolly, and we used NVivo software to kind of aggregate, to examine potential relationships among the responses obtained from the participants. And then we conducted a thematic analysis where the themes appeared through careful reduction of coding memos, and it was really interpreted to be able to deduct themes, and we discussed these themes amongst ourselves to refine the themes until we had our final themes for the analysis. And we had 7 themes that emerged in the qualitative data analysis. The first one based on the data. And so what we did was to kind of put quotes from the data sources based on the data for focus group A and focus group C. The quotes that we found relevant to each of these themes were identified. So the first thing was community norms around substance use. There was participants that just expressed some thoughts around community norms. So for example, participant 15 from focus group A says, church thinks it is not okay. Family participant 22 says family views it bad. In terms of availability of resources, some quotes that originated were, if a parent drank, they could get it out of the fridge. This was from a participant in focus group C. Another another quote from the focus group C data, stated other kids could bring it to school and give it to other kids. And then the third theme in terms of communication, when asked around like what communication was around substance use, some data arose where there was a quote which said, other 5th graders talk about how their families smoke. In terms of age of initiation, the quotes there from the participants in focus group C, drinking 21, cigarettes probably 13. And then in terms of attitudes, there were some attitudes that were expressed around substance use, negative attitudes. So a quote that came from the transcript from focus group C, participants said, not good, don't do it. In terms of perceived benefits of substance use, the reasons why kids probably would want to use the substances, a quote from the focus group C said, cause they see older kids do it and they want to do it. Then the 7th theme in terms of perceived consequences of substance use, we had, based on the data, we had 3 themes that, 3 areas of consequences that arose. So the first was physical, and then a quote from one of the participants said, if they start, they get addicted. And then another consequence was health consequences, and under that, some of the participants said, bad for your lungs. And then in terms of legal consequences, this idea of jail as a consequence for substance use. And then we had 3 tables just arising from the different questions that were asked among focus group A participants. Because there were 35 in number, we were able to quantify the responses of the qualitative data. So for the table 1, in terms of the question, what substances are kids using the most? Table 1 really has a number of the responses that participants gave. So we see the higher number of participants mentioning vaping as substances used among youths in Carter County. And then the second is, tobacco, cigarettes, and dip. We categorize that together. And then weed, marijuana, and then alcohol, and then finally pills. For the second question, where are kids using these substances? Table 2 is a quantification of those responses from the focus group A data. And so we see majority of the kids, majority of the youths indicating school. And with school, we have behind the school bathrooms as locations where kids are using these substances. Some people say parks, house, back alleys, responses like, I don't know. Some said everywhere. And then one person mentioned covered bridge. And then the third question, how are kids getting access to this substance? How are kids getting the substances? Table 3 really has a quantification of the responses, again, from focus group A participants, where predominantly most of the responses came from older kids. Then it followed by family. By family, we had we categorized family. Some people mentioned big brother, older siblings, parents, and then adults. Some people mentioned stealing, some people mentioned drug sellers, false ID online, and petco behind the store.
Okay, so in addition to the qualitative analysis, we used some of the data from the Tennessee Together survey from 2018 to 2019. So this is a statewide survey, which is funded by a portion of the state's budget allocated to programs aimed to eliminate the opioid crisis. And the goal of this survey is to assess substance use behaviors, attitudes, and perceptions of youth in 8th, 10th, and 12th grades. So for our part of the community needs assessment, we primarily did just descriptive analysis. So we established frequencies using SPSS 26 for ever use, specific substance use, recent use, and age of initiation. And then these frequencies were visualized in graph form from Microsoft Excel. So this is just some general characteristics of the Carter County survey sample. So as you can see, the majority of survey respondents were 14. Most of them were in 8th grade. The majority of them were white, and there were more females than males. So figure 1 shows the percent of youths reporting any substance use in Carter County for the Tennessee Together survey between 2018 to 2019. So 45% of the 320 overall survey respondents reported ever use. Of those reporting ever use, you get this breakdown of specific use in figure 2. So as you can see here, traditional cigarette use is the highest ever used drug in Carter County, followed by alcohol and then e-cigarettes. So then we also wanted to look at recent use, which is represented here in figure 3. So of that 45% of the sample that reported ever use, this is the frequency breakdown of recent use of drugs. So e-cigarettes were the highest recently used drugs, followed by alcohol, marijuana, and then traditional cigarettes. So there's an interesting difference in ever use of substances versus recent use of substances. And then the last kind of descriptive statistic that we wanted to look at was age of initiation. And you can see that 13 was a prominent age, and I combined all of the different substances used to look at what age was most frequently reported for all of those. So overall, this is just a brief discussion of our findings. So the qualitative findings support a community health needs assessment conducted by Ballad Health, which found that teen smoking and substance abuse were top priorities in Carter County, and identified the priority area of nicotine products, so e-cigarettes, traditional cigarettes, smokeless tobacco, and nicotine gum. As far as the quantitative findings, of those respondents reporting substance use, almost 70% have ever tried traditional cigarettes, and almost a third reported ever e-cigarette and alcohol use. As I mentioned, there's those differing patterns between ever use and recent use, where e-cigarettes were reportedly the most recently used substance, followed by alcohol and marijuana. And as I mentioned, 13 years was the most frequently reported age of initiation for that combination of substances.
Sorry, okay. Like Melissa and Fenose already indicated, we developed our problem statements based on the qualitative and the quantitative findings. So, but before I move on with the problem statements, I want to let you all know that the percentages mentioned here are from those 45% of the youths that Melissa mentioned earlier who reported current or ever using drugs, and not from the total youth population in Carter County. So talking about alcohol, like despite being perceived as a substance with great risks, alcohol was the second commonest used substance by youths in Carter County, with around 32% of them reporting ever use, while more than 12% of the youth engaging in excessive alcohol use ever. So talking about the current use, like 11.9, close to 12% of the youth reported drinking alcohol, and close to 6% of the youth reported excessive alcohol consumption in the last 30 days. Regarding traditional cigarette smoking, so they were the most commonly used drug among Carter County youths, with close to 70% of the youths reporting using traditional cigarettes, and 8.4% of them reporting current use. You know, we all are very aware that traditional cigarette smoking is the single most preventable cause of premature mortality and several other comorbidities in the United States. So this is an important issue. Talking about e-cigarettes, basically because of the wide availability of different e-cigarette devices and products and very minimal regulations on their advertisements and sales, you know, e-cigarette use is increasing not only in Carter County but throughout the nation. And in Carter County, about 31.6% of youth reported using some form of e-cigarettes, while 18.1% of the youth reported current use of e-cigarettes. Next slide. So two other substances that were commonly used by Carter County youths were marijuana and prescription and illegal drugs. So close to 18% of youth in Carter County reported ever trying marijuana, and 10.6% reported current use. You know, marijuana is the most commonly used illegal drug in the United States, and its use is associated with several short-term physical, mental, and social issues. Among the Carter County youth, 5.3% of them reported using prescription drugs, while 2.2% reported using illegal drugs ever. Further, 2.5% of the youth reported using prescription drugs in the last 30 days, while 0.6 and 0.3% reported some form of use of methamphetamine and cocaine. So, you know, use of all these high-risk substances is associated with several social, physical, financial, and mental problems that not only affect the youths who use them, but also their families and the community as a whole.
Okay, so what we did is kind of took the themes that were identified within the qualitative data and identified gaps in the quantitative data that might need to be better explored based on those qualitative themes. So one thing that we noticed is that the Tennessee Together survey measured perceived risk only, whereas the qualitative data suggested that people might associate substance use with some perceived benefits. So it could be important to assess perceived benefits of substance use in Carter County in addition to the perceived risk of substance use. Another thing we noticed is that some of the questions within the Tennessee Together survey were kind of leading. For example, one question said, how wrong do your parents or peers feel it would be for you to use different types of substances? So an alternate to that could be, how would your parents feel about you drinking alcohol? And potential responses could be in like a Likert agreement scale, where you could say they would strongly disapprove, neither disapprove nor approve, or strongly approve. And that way you're not putting that negative connotation with that substance use, and you're providing your respondents a little bit more opportunity to give their opinion instead of making it all negative. Another limitation specifically for the 2018-2019 Tennessee Together survey was that Carter County only had 8th and 10th graders. There weren't enough 12th graders to be included. So it would be helpful moving forward to get a more diverse group of individuals to respond.
So based on the data formats for the qualitative data, we had some limitations. As earlier mentioned, we did not have the full demographics of focus group participants. And so with the demographic, includes a number of participants that are just descriptive details, so we're not able to really describe our sample population. And because this is a qualitative study that was conducted among a set of convenient sampling for youths, with looking at the implications and transferability of findings. So we can only say that these results only apply to this particular population of people that were sampled. There's limits in transferability of findings for our study. And also in terms of the questions, just with like what Melissa said, the idea that some of the questions did not really elicit the kind of responses that were intended. We wanted to have more questions that were able to inform the problem statements. And so we thought that was a limitation. And in terms of just the way the questions are collected, because substance use is a very sensitive topic. So like probably, having focus groups, could have elicited some form of bias or social disability and potentially groupthink. So probably alternate sources of collection would have been better in this particular situation.
So for the limitations associated with the quantitative data, from what I could tell, the Tennessee Together survey required active parental consent, meaning that parents had to sign a consent form for participation and send it back in. So that can limit the amount of responses you get versus passive consent, which parents only have to return the form if they want their child to opt out of that survey. So that can limit responses pretty significantly. It also may have affected, this active consent may have affected self-reported responses by youth and introduced response bias. And as I mentioned briefly a second ago, there's a relatively small sample size reporting ever using substances which may be related to response bias and that active consent. So generally, active consent results in lower response rates, less diverse study sample, and fewer high-risk respondents. So based on that, we identified some recommendations.
Okay.
About the qualitative stuff.
Yeah, and so part of our recommendations for best practices we had best practices for before the data collection process, while collecting data, and after the data collection process. And so before the data collection, with the generation of questions, we just wanted to recommend that the study questions be tested and piloted through a research team to ensure that the questions are asking what they intend to ask in terms of that fidelity and formative evaluation, probably piloting it among a subsample of the population of the youth that are intended to be. This will ensure the validity and reliability of the questions. And while collecting the data, we just wanted to make sure, just kind of recommend that the wordings are simple and clear, consider the literacy of the study participants. And so for youth, probably a third grade reading level will be appropriate. Probably for adults, maybe 6th grade reading level. And then avoiding technical words, big words and unclear words that can confuse the study participants. Also, avoid leading questions and ask questions that are open-ended instead of questions that are leading, as Melissa had mentioned earlier. And finally, in terms of data collection, ensuring that the focus group data is transcribed verbatim, and just check for accuracy across the recordings. And then in terms of resources, we thought about this leveraging on existing partnership, especially with data collection, probably leveraging of existing partnership with ETSU to have interns, probably from the epidemiology department, just to be there to help with data collection and analysis of both qualitative and quantitative data.
Okay, just a couple more recommendations and then we'll open it up for questions. Sorry for going a little bit over. So one recommendation could be utilizing some information within the Youth Risk Behavior Surveillance System, which is a national surveillance system and has questions related to substance use. There's also a guide for conducting your own youth risk behavior survey. So I added that resource in there, and it outlines how you could go about that. So that might be beneficial for you guys. And I know whenever we presented in class, you mentioned how to mitigate, you mentioned that you were interested in learning about how to mitigate active consent and improving response rates. So I did a little digging and I found that some of the literature suggests that if you're working with schools, maintaining regular communication with school staff about the survey can improve those response rates. Providing incentives to schools, parents, even youth can be helpful. Having a multi-pronged approach for reaching parents. So the research recommended having direct contact, like face-to-face or over the phone. Encouraging students to return the consent forms, and attaching consent forms to other documents that need parental signature, like report cards and things like that. And then a final recommendation is to make the consent forms simple and easy to read, and kind of like what Fenose said, at a reading level that is understandable by everyone. And I think here are our references. Thank you for listening, and if you have questions, let us know.
Thank you all so much for sharing. I wanted to give everybody an opportunity to ask questions, but I also particularly wanted any feedback from Lacey as far as sort of limitations that we have as a state on surveys, and just sort of some of the background on Tennessee Together and those kinds of things. And then also, Sonia, if you wouldn't mind to kind of talk a little bit too on anything Carter County schools wise that you think would be helpful for us, or any thoughts on this kind of going forward. So any questions from anybody, and then if I could have feedback from either of you two, that would be great as well.
Well, I'll jump in since no one's chomping at the bit with questions. Nice job, guys. This data is really interesting. It's really fun to dive into. You highlighted some challenges that we have. We leave it up to the county, and specifically the school district and school, the type of consent they use. So we highly encourage passive consent, but we don't require it, because some districts would say, we're not doing it then. So we try to steer them towards passive consent because of all the issues you just raised. But if a school says we do active, then we say we respect that. Here are the materials. And then we did have even typically we would like to get a higher response rate. So even for the 8th and 10th graders, there's a note in the survey report, we didn't meet target participation. Part of that is because of active consent. We also, you can see in the schools that participated, only about half of Carter County schools participated when they were almost all selected. So we do at a county level, we do a random selection of schools to meet a target participation rate. Depending on the county size, sometimes that's all the schools. Sometimes, like if we have a larger county, that's only a sample. For Carter County, it was almost all the schools, but we only had 6 participate. So participation's definitely the #1 barrier. In terms of the questions, so we use validated questions mostly from other instruments. A lot of them are duplicated from YRBS. So that overlap is there on purpose. So that way our little counties who don't get county level YRBS data can compare across Tennessee Together and the national data. We do have some larger counties that administer their own YRBS, Knox County, Shelby County, so they get local level data. None of our other Tennessee counties, though, get that local data. So the idea is we have questions from YRBS, we have some, I think some questions that overlap with NSDA, a couple other from different validated survey measures. And so we have a mix of questions. We also have a lot of communities that have drug-free communities grants, and they have core measures that they're required to report every year. So some of the question wordings, and especially the ones that are, in my opinion, I do not speak for the state right now, I speak for myself. Some of the question wordings that you read and you're like, why is it worded this way? Those are DFC questions that every year I'm like, can we change this? And we can't. So All of your points were incredibly valid. And so this is not meant to say, oh, we can't do that. It's just kind of giving you a glimpse at the larger sort of broader context that we have to administer in. But the big takeaway is that for Carter County, if we can up participation, we are just going to get better and better data. And then one other plug for the upcoming survey, we did add a couple of other questions to disaggregate between different types of vaping use. So feedback that we consistently got from 1819 was that we ask about e-cigarettes or vaping. We don't disaggregate between vaping nicotine products and vaping marijuana products. So that has been added to this year's survey. There are specific vaping questions where vaping nicotine, vaping marijuana, and or vaping flavoring only. So, so that's an addition. Otherwise, the survey was largely unchanged because we want communities to be able to track rates over time. So yeah, I think all the points you guys brought up are super valid. And I think the takeaway for the coalition is anything we can do to increase participation, you're just gonna get better and better data.
Thank you, Lacey.
From the Carter County Schools perspective, Jillian, I remember this survey going out and remember being very frustrated that we were not able to get survey results that we wanted. And I really think that Lacey's correct. It all comes back to participation as well. And I mean, I remember almost begging people to get this survey in, and it was not. Really wasn't well received. I don't know. But as far as the school system and what we're doing, I can speak to what we're doing in after school, but during the school day, I would have to speak with others about that. But in after school, we do have drug prevention programs that are going on, but you know, you really don't know how many of them you're reaching, especially in today's time. Thank you, Jillian.
Yeah, thank you, Sonia. Any thoughts on incentivizing this or ways that we can sort of support the schools to encourage this to happen? Any thoughts on that, Sonia?
I'm sorry, Jillian, you cut out on me. Could you say that again?
Oh, you're good. Any thoughts on incentivizing this? Like anything we could do to help make this happen, or I don't know, encourage participation in any way that you can think of?
One of the things that we could do, you know, as far as after school is concerned, is we could have them do it during after school rather than trying during the school day. And that may be an option for next time. And I know that participation still will not be high, but I think that we would probably even get more back than we did. We have about, well, during non-COVID times, we've got about 650 kids enrolled in after school.
Sorry to be the bearer of bad news, but for survey design, the survey is designed to be administered to a census of 8th, 10th, 12th graders. And so if we had people that self-select into after school program, unless it was, you know, 90% of your kids, that it may or may not be possible. So Sonia, I don't want to say no, but I do just kind of want to introduce that there are certain ways we can be flexible, and then certain ways that we kind of can't, just because we're worried about introducing bias into the data. But we will bend over backwards to make it work. We've been doing a lot this year, obviously online. So it is online or in person. It's totally up to the schools to choose. And so that has been, I think, really helpful with some of our communities that struggled last time. So I'd love to talk with you more about that. If you, maybe with Jillian at some point offline, we can chat about that and see if we can brainstorm additional ways. I will say a lot of counties that were resistant, schools specifically that were resistant last time, when they look at the full report, the statewide report, and they look at the data that the participating counties got access to, that has convinced a lot of people, that has incentivized people this time. Like we've already gotten a bunch of communities that didn't participate last time, and given COVID, like that's crazy to me, that they're opting in. So sharing the materials, and there's I can send, actually I'm going to put the link in the chat right now, is definitely, it has helped incentivize so far.
Thank you. For the sake of time, I'm going to go ahead and move on, but I would love to continue this conversation and help us get to a place where we can get some more involvement, hopefully this year. If you have contacts with schools or have any avenues that you think would be helpful for us, please reach out to me and let me know. We are currently kind of spreading the word about this next survey, so it's really beautiful timing for us to be talking about this now and be able to hopefully get the word out there and get some participation for this next survey too. So thank you all so much. I can't say enough about how much we appreciate this data and this conversation, and just the work that you all put into this is so very appreciated by all of us. So we will move on to our second student presentation, focusing on our Youth Coalition evaluation efforts.
Okay, let me share my screen here. Can you all see my screen? I'm sorry, can you all see the screen? Okay.
Yeah.
All right. Okay. Yeah, my name is Adekunle. You can call me Ade, and I have my other group members that will be discussing our proposal this afternoon. So this proposal is basically concerning evaluation of the Collier County Drug Prevention Youth Coalition. So a quick outline, discuss and outsource the logic model, the health belief model that influenced the development of our survey, and we'll discuss evidence-based evaluation strategies, some recommendations, and we'll take questions after. So to give some context, some background about the logic model, going by one of the tenets of engaging stakeholders, we met with representatives of the Collier County Coalition, and we had a wonderful series of meetings and discussions, and we agreed on this with shared interests. The first part talks about the inputs from our team, the ETSU evaluation team, and from the Collier County team. So activities include designing of the logic model, providing timelines, and providing evidence-based survey metrics, and also carrying the members of the team along. So some outputs, one important one that I would emphasize on is the fact sheet. We earlier sent out the fact sheet. I'm sure if we don't have access to it, we'll get it later. It's one of the things we decided to put together to be able to give some quick background information about the county and the coalition and the evaluation strategy. And we'll see other outputs, which is the survey and the proposal, which we are presenting today. And for our outcomes, short-term, intermediate, and long-term outcomes. Overall, we hope that at the end of our inputs, we'll be able to reduce the percent of children in Carter County who initiate, experiment, or maintain alcohol or drug use. So our main data source that would influence the progress being made would be the self-efficacy and health belief survey that we'll be talking about. Now, to design the survey, we applied the health belief model. This is a commonly used model. It was first used in the 1950s, and it has evolved from the focused use to many other applications. And now it's one of the main guiding frameworks for health behavior interventions. Now, this theory actually states that the probability of an individual taking up a health behavior depends on about 6 constructs. Perceived susceptibility, which is the risk of taking up the health behavior, the perceived severity. Some individuals also consider the consequences. And my colleagues mentioned about some consequences from the qualitative study about the health, physical consequences, the health, legal consequences. So some of these things would influence if an individual will take up a health behavior or not. Perceived benefits, I mean, what is in it for me? That's what some people consider before they can take up a behavior. Perceived barriers, what are the hindrances to taking up the behavior and taking behavior? Cues to action, what are the prompts that activate that readiness for taking up the behavior? And self-efficacy, which is the confidence in one's ability to change a behavior. So these are the constructs that we put together that influence development of our survey. I'll introduce Esther to discuss.
Hello, everyone. Can you hear me?
Yeah.
Yes, because I knew my mic was having issues the other time. So I'm Esther. I will be going through the survey questionnaire that we created. So we created this survey questionnaire that consisted of 38 questions. And I'll be going through the example of the questions and the responses, as well as the sources from which we got the questions from. So an important thing I want to state is that we utilize the health belief model to kind of form this questionnaire. So firstly, for demographics, we're looking at questions like, what is your current age? What was your gender at birth? Of course, I couldn't add all the demographic questions that we included, but we sent this report to Dr. Slawson and Jillian as well. So the responses here for age is from 9 to 18 years and gender male to female. The next is substance use. So we based the major question for substance use on alcoholic beverage use, as well as illicit drug use. And the response is yes or no. This was gotten from the National Survey on Drug Use and Health. This is a national longitudinal survey, of course, is standard and has been severally validated, and it's reliable. The next is perceived susceptibility. So the question is, if one of your best friends offered you a drink of alcoholic beverage and or illicit drug, would you use it? And so the response from definitely yes to definitely not. And we got it from the National Youth Tobacco Survey, as well as Population Assessment of Tobacco and Health Survey. These are all national surveys. I believe the National Youth Tobacco Survey has been existing since the 1990s, and Population Assessment of Tobacco and Health Survey since 2013. We also added perceived severity. I know my colleague has explained what that means, but one of the questions I decided to add to this slide is, how long do you think someone has to use alcohol and or illicit drugs before it harms their health? And the response varies from it will never harm their health to 20 years or more. And this is from NYTS. Next slide, please. Can you go to next slide? Thanks. Okay, so perceived benefits is the next. The question here is, alcohol and or illicit drugs helps me be friends with others who drink alcohol or use drugs. You know, we're dealing with youth here. So knowing some of these things are very important. The response here is yes, no, or not applicable. We got this from Perceived Benefits of Drinking Scale. This was actually created or developed in the 1984. And it consisted of about 5 questions, but were specifically directed to drinking. But we kind of revised it to make sure we're not only going to be dealing with alcohol alone, but also illicit drugs. So the next is perceived barrier. So the question is, it is hard to quit because so many others around me are using alcohol and or illicit drugs, with responses ranging from strongly agree to strongly disagree. As the name implies, we got this from Barriers to Quitting Smoking in Substance Abuse Treatment Survey. And this specifically just kind of asks questions related to barriers to quitting smoking, but we kind of framed it to make sure that it was directed to substance use in general. Then cues to action, examples of questions is, in the past 12 months, have you stopped using alcohol and or illicit drugs for 1 day or longer because you were trying to quit for good? Yes, no, or not applicable. This from the past survey. And finally, self-efficacy. How confident would you be not to drink alcohol and or use illicit drugs when you are emotionally upset, to be feeling down, angry, afraid, or guilty? This is from not, the response is from not at all to extremely. And we got this from alcohol abstinence self-efficacy. So what I just want to say is that we ensured that all these questions were gotten from validated surveys that are very reliable. And we also conducted face validity. So it's not just like we just got all these questions and we assumed that people could understand it. We sent this to Dr. Slawson, who reviewed it for us and said everything was good, but we also recommend that this questionnaire be like kind of pilot tested, like given to the Youth Coalition members to take. Of course, it's 38 questions, and I think and I believe that the questions are easy to understand. So that's all about survey questions. Now next to Melissa. Melissa, you can go ahead. Sorry, Kathleen, sorry.
It's all right. Hi, so I'm going to be talking a little bit about some evidence-based evaluation strategies. So what's great is that y'all already have access to the Dover Youth to Youth evaluation framework. This framework is divided into 3 key components: monitoring and feedback, program fidelity, and outcome evaluation. So the monitoring and feedback component tracks data on what activities are being done, who is engaging in these activities, which allows our program staff to make real-time adjustments and to ensure that the program is running efficiently and effectively. It also allows program staff to quantify the number of activities they're providing, how many participants are being reached, the dosage of activities and program components that participants are then exposed to. It also allows for the gauging of participant satisfaction and identify if parents or guardians noticed any significant changes in youth participation as a result of the program. So the next component of the youth to youth model is program fidelity, which is ensuring that the program is being delivered in the way that it's intended to, meaning that is the program engaging a wide range of participants and maintaining relationships through successful management and administration of the program. Lastly, the outcome evaluation. So the youth to youth model suggests utilizing a pre and post test to evaluate participants' public speaking and presentation skills as a means of measuring program impact. So I'll talk a little bit more about this outcome strategy in our recommendations. So moving forward, I'm now going to talk a little bit about journey mapping. So journey mapping began as results mapping. It's an evaluation tool that can be used to bridge the gap between process and outcome evaluations. So really, are we doing things right? And is it leading to the end result that we're hoping to see? So results mapping was utilized by dozens of programs across the country, and it's intended to evaluate programs whose results aren't easily quantified such as substance use prevention programs. So this is just saying that attendance and program satisfaction, which are key metrics that have been used to evaluate these types of programs in the past, may not be the most accurate predictors of adolescent substance use or avoidance. So the results mapping strategy involves the development of stories, which are narrative summaries by the program staff about the program's activities, accomplishments, prospectively and retrospectively. These narratives can be coded and given a numerical score, which estimates their potential reach and impact. Scores indicate how each activity contributes towards future goals, such as reduced substance use. Scores can be increased by utilization of a change agent. A change agent is a person who is not program staff that is bringing in their own experiences and resources to support the intervention. Further additional points can be garnered if you're utilizing multiple change agents within an activity. So limitations of results mapping noted in the academic literature is that the mapping and coding process of the stories can eliminate some of the personal aspects of the narrative, and further coding these result maps did not promote new learning or provocative feedback from program staff. So what the creators of results mapping did was kind of shift their perspective from stories to journeys. Journey mapping is kind of the new overarching idea that is characterized by the idea that while there's variations in the path a person can take, these variations live within the well-defined archetype of the hero's journey, kind of like the Odyssey of it all. So the hero's journey was adapted and divided into 3 stages: contemplation and preparation, actions and successes, and the legacy. Within each phase, there are 3 to 8 levels, each of which have 3 sub-levels. And this division allows for program staff and program participants to more specifically track progress through the intervention program. So a person's progress through the journey can be mapped graphically or quantified numerically, and the journey score can serve to identify progress. Now, the scoring system does not arbitrarily set pass or fail point levels, but instead allows staff and participants to quantify which phase or level each participant has reached. So, as I mentioned, journey mapping can be completed by program staff, but new recommendations are suggesting really involving participants in mapping their own journeys through a program, because this gets more buy-in from your participants, giving them more autonomy over their own program experience and a stake in the ongoing program improvement. So on average, a detailed journey mapping entry may take 5 to 10 minutes, and they can be done monthly, as was suggested by the literature. So the last evidence-based strategy I'm going to talk about is a pattern-centered approach. So there are 2 types of adolescent substance users: adolescent limited and life course persistent users. Adolescent limited substance users experiment due to peer and social influences, whereas life course persistent substance users is attributed more towards neuropsychological deficits experienced in early life, as well as intrapersonal characteristics, So adolescent substance use can also further be defined by the frequency of use and the pattern of the consumption. A major limitation noted in the literature is that previous substance use prevention program didn't include the ability to differentiate and quantify the difference between the types of substance uses in adolescents, and that authors note that evaluations that fail to differentiate between the types of substance use in adolescents can mask the effects of intervention programs. So the thought of pattern-centered approaches is that by comparing the patterns by which adolescents consume substances, evaluators can identify the influence of an intervention on developmental changes in substance use and differentiate between the program effects and what could be called random effects. Pattern-centered approaches are appropriate for clinical interventions or programs such as the Youth Coalition, which go on over multiple years. I apologize. A pattern-centered approach evaluates 3 types of programs effects. So first, changing the likelihood of an individual to engage in a specific pattern. So this is looking to change an individual's development of the behavior. Evidence suggests that the patterns of use can be better used to judge program effectiveness rather than the level of substance use. Second, pattern-centered approaches look at changing the level of use within patterns. So this is saying that program evaluators can examine the growth or decline of substance use within groups compared to the whole sample. And lastly, they look at changes in the negative consequences of substance patterns use. This is good for harm reduction programs. All three types of effects can be used to assess the program for the Youth Coalition, and pattern-centered approaches additionally offer an important perspective on the development of behaviors, especially in long-term intervention programs. They can also be used to inform the timing and content of intervention components. All right, moving forward to recommendations. Broadly, we are suggesting that in light of the ever-evolving COVID-19 pandemic, that the Youth Coalition adapt all of the activity log, the program fidelity monitoring feedback, and outcome evaluations to a digital format. We've suggested the use of either Google Forms or social media for each of those, specifically talking about activity logs, which allow the coalition program staff to measure participation and reach. They can use specific social media posts or create specific login requests for their Zoom meetings to help get a clear log of how many people are attending each activity. So, excuse me, I'm sorry. Our next recommendation would be to use our survey tool to move as students move into each phase. So the Dover Youth to Youth model only suggests using a pre and post test, but the way the Youth Coalition is structured, they have a very clear break between the different, moving from gaining knowledge and confidence into phase 2 and towards peer mentorship. So we suggest having kind of a longitudinal approach to survey so that you can see more direct changes as they move through the program. We also recommend integrating a journey mapping aspect into Youth Coalition activities, further investing our Youth Coalition participants into the program activities, and so that they can measure their own progress as well and grow in self-efficacy. And then lastly, we suggest applying a pattern-centered approach to analysis, which can be used to improve the timing and content of educational modules provided by the coalition. Thank you so much. I think we're ready to move into questions.
Thank y'all so much for your work on this, and I'm really excited to implement some of these things with our Youth Coalition and kind of see if we can't evaluate their progress and have that to share with the coalition and with other youth coalitions across the state and country. So we really, really appreciate everything you all did to work on this and look forward to putting it to use. So I know we are short on time, but I very quickly wanted to let everyone know that we have received the results of the Carter County Collaboration Survey. So thanks to everybody that took that. And we will be moving forward with a meeting with combined forces of Carter County Drug Prevention, Carter County Health Council, and Carter County Community Advisory Board. So the last survey, we asked everyone's preference for meeting times, and the most popular choice, actually by a landslide, was Thursdays from 12 to 1:30. And so starting in January, our new meeting time will be Thursdays 12 to 1:30, and it will be a collaborative between us and Health Council and CAB. So we're really, really excited about that moving forward. We think that it will be a great opportunity for lots of people to be around the same table, and for many of you that I know are members of lots of different meetings, to have this one space, hopefully, where we can share events and activities and be around the same table discussing all of them at once instead of several times. So that will go out in our newsletter. We also are working on a calendar invite for that, so everybody should get those within the next week or so to be able to add to their calendars. I did want to give anybody who has updates a few minutes to share those. If you need to go, thank you for being here. I'm really grateful for all of you and hope everyone has a happy holidays. We won't see you again before Christmas and New Year's and all of that fun stuff. So I'll give y'all a few minutes to share if there's anything you want to update on or share with the group.
So thank you all for having us. I'm sure we are ready to head out as a group because we have a series of deadlines to meet up. So thank you all for having us.
Thank you, guys.
Thank
Bye.
you all. Thank you. Thank you.
Thank you.
Thank you.
That was a lot of information. It was good though.
Was definitely a lot. They did a really awesome job kind of taking our needs assessment and creating it into something usable and hopefully getting us some tools to evaluate Youth Coalition and all of that. And so it's definitely a lot. Dolly and I have been processing for a couple weeks now. All of the recommendations and all of those things. So yeah, good stuff.
Yeah.
Anybody have updates they want to share?
Yeah, I'd like to have an update.
Okay.
We done our last high school student today. So that was a success, I guess, for the most part, Dolly. Whenever we had them show up anyway. So that's our last one. That was a great success so nice to collaborate with the high school and the coalition to be able to do that for them through their clinicals. So that was cool. We done our the Wonderland kicked off today. We're going to need more food. We had 57 people come through today. So that was a huge success today. Everyone's very excited. We had new people and of course our regulars. It's been coming ever since August. So that's it's always good. I think we fed over 1,500 kids so far with our feeding programs since summertime. We brought Vincent Red on as a mentor. Everybody's stoked about that. The post on that reached over 1,500 people and still is climbing. So the word about the program's getting out there. You know, we've expanded to Mountain City, got 5 mentors up there. My battery's running low, and the program's rolling. Even though COVID-19's hitting us in the face, we're hitting it right back. So I'm glad to be a part of this, and thank you guys. And that's about all I have right now.
Thank you, Shannon. The high school program he was talking about, if you aren't aware of what we're doing there, we partnered with Elizabethton High School to do a public health rotation of some students. And so we have a different EHS student each week that gets to spend a day with me, a day with Dolly, a day with Shannon, and also kind of with some community partners thrown in there as well. And so we have had lots and lots of students since the beginning of the school year, and it has been just a really cool opportunity, hopefully for them to be able to get an idea of what public health is, what we do, what the Youth Coalition is, and then also for us just to kind of have an opportunity to work one-on-one with some students. So thanks for sharing about that, Shannon. I think Dolly has some updates too.
Yeah, so I'm just really excited to share this idea that I'm working on bringing into a reality here, and that is creating support groups for folks who currently have a mental health illness, and also parents or spouses, partners of parents of children with mental health issues, or spouses of people with mental health issues. So something that I really want us to expand on is offering support for people with mental health disorders, and particularly, sorry, kid came out knocking at the door. Okay, my biggest thing is, no, I can't talk today. Anyways, I want to create support groups. One is a youth with mental health issues or perceived. So if they're undiagnosed, we could still have a support group for them. I'm thinking of something along the lines of it being peer-led or peer-driven with a therapist present at each of the sessions to help moderate or drive some of the conversations and discussions along the way. The biggest objective is to minimize trauma in the community at the family level. So providing support and protective factors for those with mental health illnesses or for those caring for them, just to decrease the negative impacts such as abuse, substance use disorder, school dropouts, self-harm, and so on. So I would also like these support groups to help decrease stigma around talking about mental health and educate on mental health and illnesses as well. I know a lot of people at this time have really struggled not only with our mental health issues, but struggled with the family dynamics, with family members seeing every high and low with mental health issues throughout this pandemic. And so anyways, just being able to have a support group where peers can get together and talk about some of their struggles, or parents can get together and talk about the struggles that they're dealing with their kids, just to provide that support so that they don't feel so alone or isolated. Currently, the idea is to have this in a virtual format until it is safe to meet in person. And if we get to a point where we continue doing this, or wherever we are in the progress, if it's safe to meet in person, I would love to have a location nailed down, maybe possibly some meal accommodations, and work out the details when that comes, oh my gosh, I can't talk, when time comes to cross that bridge. But the biggest thing is creating these support groups for the purposes of helping us meet these objectives that we currently have in our vision and mission. So it's a big idea that I have, and looking forward to hearing some feedback or any suggestions any of y'all may have.
Emma, would you care to also talk about the support group you are working on?
Yes, I am aiming to create the first ever Gay Straight Alliance in Tennessee. So we're going to go and try to create that. I'm going to go ahead and read you guys my elevator speech, and you can tell me kind of what you think about it. Did you know there is one minority that vapes, smokes, and are 3 times more likely to commit suicide more than any other minority? This group is the LGBTQ community. All these students are literally dying because of a lack of understanding and acceptance. I strive towards creating a CCDP GSA club because I try to live by the Bible verse Mark 12:31. You shall love your neighbor as yourself. There is no commandment greater than these. A GSA club will be a place where LGBTQ plus youth and allies can meet people who accept them for who they are. These students have the potential to change the world. With your help, we can be the first GSA group in Tennessee and lower rates of suicide within our community. I've already partnered with CCDP and have reached out to ETSU Pride Center. I hope I can receive your help as well. So that's what I've got for my elevator speech, and I really do hope to create one probably sometime in January.
I think it sounds really good. I think you have the hook at the beginning and then sort of surprise them with the data that they might not have expected about suicide rates and who do you think is most. So I really like the initial hook and the brevity of it. So you definitely have my support, and thank you for your leadership in this.
Thank you so much for that feedback. But yeah, I've just been kind of working on this for a while. I made an action plan and kind of a sustainability plan as well.
So one thing, Em, and Molly can talk about this a little bit more if she wants to, but one of the things just around language. So when we say committed suicide, it feels a little bit like they committed a crime or they did something wrong. And so shifting the language from committed to died by suicide, or Molly can throw out other ways to say that maybe too, but just changing that so it doesn't feel so much like they committed something or did something wrong, but instead died by suicide.
honestly, at die-by suicide tends to be the one that's most well received. I mean, there's other options like suicided, but just looking at everyone's faces when I say that, no one likes to hear the word suicided is a verb. But to be honest, good job, like with that, you caught my attention immediately. Like I barely even noticed the committed verbiage. So you do such a good job with everything. I think if we could just tweak that a little bit, and I'm happy to help with any of that I can. But amazing job. This is an awesome project.
Thank you. I just went and fixed it now. I just didn't know how to word it, so thank you.
All right, so we will be getting some information out to everybody about support groups really soon, we hope. And so if you all will help kind of spread the word about those things, and just share with anybody who may be interested in any of those, that would be super helpful. Anything else y'all have coming up, or anything you want to share?
I guess the only thing that I would say is a quick update about the syringe issue in Johnson City. I don't know if any of you were copied on that email. I accidentally sent the meeting invite again from our last meeting when I clicked it, because I just meant to update people. But I did talk with Ballad Health, and they are going to explore what it would look like to put a community-wide syringe disposal box in Johnson City. And I also mentioned that maybe it could be helpful in Carter or Johnson County, because there are folks who use syringes, for medical reasons, not just, intravenous drug users. And that's where the stigma is. And so they're exploring what would it look like. Their current incineration drop-off points are closed because of COVID. What would it look like to install some large, safe boxes in the downtown areas of our surrounding counties? Because they already go around and pick up the syringes from all the urgent cares. And so they already have a route. They could easily empty another box and do that. And so they're looking into that. And it would just be a community-wide, sort of like a medicine drop box, but it's specific for syringes. So that's the update that I have. I don't know the length of time that it takes to get answers on things like that. And we only talked yesterday. So that's the update I have. And I did mention Carter. I spoke for you without asking you, but I thought, what the heck, if you also had a box at the same time some other folks were getting a box, that made sense.
Yes, thank you for including us. It is a huge need. Honestly, I think since 2017, every single drug take back we've had people bring needles. And it's consistent with people bringing them throughout the year too. And our sweet police chief kind of takes them sometimes and doesn't want to turn them away, but really we don't have a good system for taking them or telling people what to do with them. And so I absolutely, please speak for us that we really need this and would benefit from it. So thanks for including us in that conversation. All right, anybody else have anything?
Not about my own stuff, but I do, just a thought I was having about the syringe drop off. I was wondering if anyone had considered either getting with the STEP TN program and with Deirdre at the STEP TN program and seeing about putting information about that program on those boxes, because they do have things that that the boxes necessarily won't, like the wound care and things like that they might not necessarily. They might benefit from that service if someone does come to drop things off. I didn't know if that would be applicable or just something to consider about ways to partner with them on this.
Yeah, we've been talking with them from the sort of outset. And the initial problem was used syringes probably disposed of improperly because it was for folks that didn't have a prescription who were using non-medically. And could be caught with paraphernalia. So really it's the laws that I think that are making people throw them down. And so we went that route, Molly, at first with, let's make them available for folks who are using non-medically. And if we put it there, then we can put all sorts of STEP TN, we can put information about treatment, we can do all of these things. But it seems like there's great resistance to focusing on that population. And what I'm feeling is that a more general opportunity to just place it, if it just so happens to be placed in downtown areas where folks are using non-medically, perfect. So yes, I think we have an opportunity, but I think highlighting it for this subpopulation right now has been a sticking point and has been.
That makes, hearing you say that, that makes perfect sense. Like this is, and who knows down on the line, but right now, foot in the door, what you guys have going is the best option. That makes perfect sense. I just hadn't thought about it that way.
Yeah, and we'll see. It's still so up in the air. So if Ballard says no, then we're back to the drawing board. What can we do for folks? And maybe we just give them individual disposal containers from Step TN, even if they're not card carrying members. So that is, we will fall back on that. But right now, it seems like the movement is easier when we talk about everyone who uses syringes. So yeah, good call though.
All right, anybody else? Thank y'all for being here. I know we went way over today with all of the students presenting. So thanks for hanging in there with us. And I will see you all in January for our first collaborative meeting. If you have any feedback about that in the meantime, any thoughts or ideas, Dolly's gonna work on kind of what our subcommittee group will look like, which I assume it will be similar to what we do here every month. But Dolly really wants to work in some more action items and those kinds of things too. So if you're interested in supporting that or have thoughts on that, please reach out to her. And I will see everyone in January.
Bye, friends.